Hello, my name is Valeria Oñate. I will talk about reversible loss of vision in malignant hypertension. Intro. High blood pressure affects approximately 30% of the adult population. In 90% of cases, the etiology is undetermined. In the rest, we find causes such as kidney and endocrinological disease. It can have chronic, more frequent, or acute cures. In both presentations, it can cause kidney, brain, hair, and age injury.
Hypertensive retinopathy. In hypertensive retinopathy, in the earlier stages, there are AV nipping, changes in the direction of the arterioles, then hemorrhages and aneurysms, and in the grade 4, there is optic disc edema. So what happens in hypertensive retinopathy, that because of the arteriosclerosis, there is arterial wall injury, vasospasm, and a decrease in the arterial lumen, increased tortuosity, and decreased supply. So see, this is the normal one, the lumen is normal. Because of the arteriosclerosis and hypertension, the lumen gets narrowed, and then there is a directional change of the arteriole. So what's the increased arteriolar light reflex? In hypertensive retinopathy, there is copper wire and silver wire in the later stage. The AV crossing defect in the earlier stages, and then hemorrhages and cotton wool exudates. In grade 3, we have flame-shaped hemorrhages and cotton wool exudates, and grade 4 is the optic disc edema. So this is AV nicking, the arterial wall direction is changed, venous blood column is compressed. And this is here is the copper wire and silver wire. What's a cotton wool exudate? This is the normal nerve, and this is a solen axon with intracytoplasmic bodies. It's a focal infarct of the nerve fiber layer. That's known as cotton wool spots. What happens in hypertension? What does it cause? Hypertension causes sclerosis of the retinal arterioles, splinter hemorrhages, focal infarcts of the nerve fibers, cotton wool spots, and leakage of the lipids and fluid, the hard exudates. Why there is sudden visual loss in hypertensive crisis? Sudden visual loss in hypertensive crisis is due to vasospasm of the retinal arteriole and retinal ischemia, and due to ischemic optic disc swelling. So the blood pressure should not be reduced precipitously because it may cause optic disc infarction from hypoperfusion.
Ocular involvement and the possibility of exploring in vivo by means of ambulation of the fundus give the ophthalmologists the possibility of establishing the severity of hypertensive condition and occasions making the first diagnosis happen. Program 1 of retinopathy, we can find flank hemorrhage at the level of the nerve fiber layer, hard exudates in the posterior pole, and soft exudates due to microfractions to the occlusion of the terminal arterioles. They may also by ischemia and level of chronic and serious retinal. Program 2. In addition to the marked increase in blood pressure associated with papillary edema and retinal hemorrhages and exudates, the fluid picture of malignant hypertension can include manifestations of hypertensive encephalopathy such as severe headache, vomiting, visual disturbance, transient paralysis, seizures, stupor, and coma. Program 3. Although malignant hypertension is rarely the first manifestation in defining the blood pressure problem, in our case, it was on the main systemic symptoms was decreased visions, which also led us to suspect hypertensive symptoms. And the conclusion of this, malignant hypertension can result of acute substantial loss of vision owing to ischemic optic neuropathy and severe maculopathy. Home diagnosis and treatment may restore vision and retinal anatomy without any intervention in the eye. Thank you.